So hi, I'm Dr. Michael Jain. I'm in the Department of Blood and Marrow Transplant and Cellular Immunotherapy at Moffitt Cancer Center. And we're here at the American Society for Hematology annual meeting in New Orleans, Louisiana. And I'm here today to talk about one of our abstracts that we've done in collaboration with some European centers to understand the systems factors as to why some patients do well with CAR T-cell therapy and why some other patients may not do as well. So CAR T-cell therapy is a really innovative new type of cancer therapy that does genetic engineering of a patient's immune cells, their T cells, to turn them into anti-cancer cells to try and cure people of their lymphoma. And Moffitt Cancer Center is one of the leading centers in the world for providing this type of therapy. And one of the things that we want to understand is, what are some of the systems factors that lead to whether patients do well or not with CAR T-cell therapy? Now, one of the things we started off by noticing was the outcomes in the European Union with CAR T-cell therapy were not as good as we were experiencing at Moffitt Cancer Center. So if you look at what we call progression-free survival, the green curve, patients at Moffitt, at 1 year after CAR T-cell therapy, almost half of them were in remission. Whereas in the European Union, fewer of the patients, only 26%, remained in remission at that time. Now, this was very curious to us because the CAR T-cells that are given in Europe are the same CAR T-cells that are given in the United States, and there's no clear reason why this should be the case. So we embarked on a study that compared our patients and our outcomes here at Moffitt to those in Germany and Spain to understand what are the factors that lead to these poorer outcomes that are being experienced in Europe. And we had several hypotheses. First, we wondered if the patients were different. Were patients being referred later in Europe than they were being referred in the United States, so that by the time they were able to receive their CAR T-cell therapy, they had larger tumors or were perhaps more sick. And therefore, when they received the CAR T-cell therapy, the outcomes would not be as good. We also wondered whether the manufacturing of CAR T-cells, which is typically slower in Europe than it is in the United States, meant that there was a longer duration of time before patients could receive this therapy, meaning that the outcomes could be worse for that reason. Finally, in the European Union, there was a greater use of a different type of CAR T-cell product than is used in the United States, and we wondered whether that was related to the outcomes that we were seeing. So we did a series of analyses, and it was a great collaboration going on between our center and the centers in Europe. And it turned out that the main reason why patients were not doing as well with CAR T-cell therapy in Europe compared to the United States was related to the fact that these patients were sicker at the time they were being considered for CAR T-cell therapy. They had higher tumor burden, they had higher levels of inflammatory markers such as ferritin and C-reactive protein. And this meant that then when the CAR T-cells were administered, they were less able to overcome the patient's tumor burden and lead to prolonged remissions. Another factor that we noticed was, as expected, the length of time between the time when a doctor wanted to give the CAR T-cells and the time that it was actually infused was longer in Europe compared to the United States. And then finally, the greater use of tisagenlecleucel, a different type of CAR T-cell product, compared to the United States, where we use another CAR T called the axicabtagene ciloleucel, led to poorer outcomes. So putting all these factors together, we now understand better what are the factors that lead to really good outcomes in CAR T-cell therapy and how systems can influence the outcomes that patients get. You really want patients to come to CAR T-cell therapy before the disease has been allowed to grow and before all these inflammatory markers occur in the patients. You really want to expedite so that there's a really quick turnaround between the time that a patient is seen and the time that a patient gets their CAR T-cell therapy. And finally, you want to use the best CAR T-cell therapy available to reduce the risk of relapse. And we think at Moffitt Cancer Center, we've really mastered all of these factors and give the best possible outcomes to patients with lymphoma who are receiving these types of therapy. So thank you very much, and we really enjoyed being a part of this collaboration, and we hope to even improve the outcomes further going forward in the future.